This program is brought to you by Emory University.
Good morning. We're going to go ahead and get started, and I'm going to let someone else introduce our speaker, but I had two important announcements to the faculty and to the fellows as we move forward. One is that we are in our holiday Christmas drive, and you've been getting bombarded with some emails for our kids campaign. So that's a campaign to raise funds for support children that are in the care of the Fulton County CASA, that's the court-appointed special advocates. And I think you've gotten some emails, and there's little things you can click on there to go PayPal directly, etc. The idea is we're raising funds to try to buy Christmas or holiday gifts for these children. Last year, our goal is about 80 kids, so that's a big goal. Last year we raised almost $10,000, and that's the goal again this year. We're aligning again with the Department of Medicine, some folks in the Emory Clinic, and this year WishCab building is on board, so hopefully that'll help us out as well. So you'll be getting some emails about that, and just keep your eyes open. We're also going to need help with some activities around that with some of the shopping and wrap. And with that, I'll turn it over to Dr. Larakis, who will introduce our speaker today.
Thank you, Bob. Good morning. Today is a great pleasure for me to welcome and introduce to you our speaker, Professor Pibarot from Canada. And he's a great friend. And also he is the world's expert on valvular heart disease. And he has spent his career in developing novel ways to diagnose and treat valvular heart disease. He's currently a professor of medicine at the University of Laval and also holds the Canada Research Chair for valvular heart disease. For the ones of you who don't know, and I'll say 1-2 minutes, he has a very interesting career path. Actually, he did a doctorate in veterinary medicine in Lyon, France. And then he went to Montreal for internship when he got very interested in valvular heart disease, despite that his mentors were telling him to not waste his time, because there was no future in valvular heart disease. They were telling him to focus on coronary anatomy and physiology and electrophysiology, but he moved on and he pursued his passion, which was valvular heart disease, and he did a PhD in the University of Montreal of Biomedical Sciences. And actually he has both the best of both ways, a clinical lab, and also through his collaboration with the Heart and Lung Institute in Laval, he's able to be part of every major trial for surgical as well as today transcatheter heart valves. One of his first concepts that he studied was the prosthesis-patient mismatch. And that was done in the early 1990s, and he told me it took about 10 years for people to start believing in that theme and understand and believe on him how important it was and how a problem was. One of his latest concepts that he will talk to us today, and also is part of our collaboration between our two institutions, is low flow AS. And I want to assure Dr. Pibarot that this will not take 10 years for us to believe it, because we see it actually every day, many times. So I want to welcome you and thank you for coming. Philippe.
Thank you, Stam. It's a great pleasure and honor for me to be here, and also I think it's a great opportunity to celebrate our collaboration and friendship. And I had a wonderful dinner with Stam yesterday, and some of you, and in a wonderful Greek restaurant, as you may expect. Being with Stam, this was really superb. So we're going to talk about this challenging and very hot topic of low flow, low gradient aortic stenosis. But before getting started, I would like to mention a few disclosure. In particular, we are the core lab for the SAPIEN 3 trial, so this might be the most important one. I'm going to start with my first publication in cardiology, which was, as Stan mentioned, my background. I come from veterinary medicine, and my first publication was in Equine Journal. This was about the implantation of a pacemaker in a donkey. But this was a very special donkey because this donkey was the mascot of a daycare system with young kids. And this was a 500-pound donkey. Unfortunately, developed third-degree AV block and was doing 3 to 5 syncope per day, which of course become dangerous and became a risk factor for the kids. So we had this donkey fixed with a cardiac surgeon. We had to put epicardial lead at the time because the endovenous lead were not long enough for this donkey, and he came back to business and had a wonderful career then after. So we're going to talk about this aortic stenosis, and as you know, I mean, according to the current guidelines, there is a class 1 indication for aortic valve replacement when there is a severe stenosis, defined according to this criteria that you know very well, so the peak jet velocity higher than 4, mean gradient higher than 40, valve area smaller than 1, or index smaller than 0.6. So severe stenosis plus symptoms, or LV systolic dysfunction, which is defined in the guideline as an LV ejection fraction lower than 50%. And then you have this type of patients, I don't know if no, it's not moving, but it's not a big problem. But you have, for example, this lady with symptomatic as a preserved LV ejection fraction, and you have here, peak jet velocity of 5.1, mean gradient 64, small valve area 0.65, index very small. So I mean here there is not much uncertainty. You have a patient with a very severe stenosis. She is symptomatic. So I mean, it's a class 1 indication for valve replacement if there is no other comorbidities. Okay. But as you know from your practice, this is not as simple. And I'm sure, when I will show you this situation, you say, oh, of course, I see many of these patients. You're often confronted to patients where you have a small valve area that would tell you, the stenosis is severe, but the mean gradient is not severe. It is moderate. Like the typical thing, you have a valve area of 0.8, a mean gradient of 30. And then, of course, this raises uncertainty about the true severity of the stenosis and therefore about the indication for surgery, particularly if the patient is symptomatic. So one of the main cause of this discordance between valve area and gradient, so small valve area and low gradient, is the presence of a low flow. Because if the patient is in low flow, you are in trouble. Because then the assessment of stenosis severity is much more complex, because in low flow, you're going to have a small valve area, but you have a low gradient because the gradient, if you remember the Golin formula somewhat rearranged, the flow is, the gradient is highly dependent on flow. It is a squared function of flow. So if the stroke volume, if the flow is reduced by 30%, the gradient will be reduced by 60%. So it may be pseudo-normalized, okay? So at low flow, you cannot differentiate a true severe stenosis that will benefit from valve replacement versus a pseudo-severe stenosis where, in fact, the flow is too low. The forces applied against the leaflets are not sufficient to completely open a valve that is maybe only moderately stenotic. So we'll see how to differentiate these two situations. You need to increase the flow and reassess the gradient and valve area. But before getting into that, I would like to emphasize that there are actually two main types, two main patterns of low flow. We have the normal flow high gradient that we discussed. The first patient I showed you is a typical example of patients where there is no big deal, no big issue. I mean, these patients, they have a normal LV ejection fraction, normal flow. If they have a severe stenosis, they have a high gradient. If they have symptoms, they have a class 1 indication for valve replacement. But unfortunately, you have about 5 to 10% of the ES population who have a depressed systolic function, low LVEF, generally enlarged LV cavities, and they have a reduced flow across the valve. And so because of this low flow, they may have a low gradient despite a severe stenosis. And this is a highly challenging group of patients, both in terms of diagnosis, I will show you a few cases, and in terms of therapeutic management. And now there is another type of low flow, more recently described. We reported this type of low flow for the first time in 2007, and this is the paradoxical low flow. As opposed to the classical low flow on the right with the low EF, these patients with paradoxical low flow have a normal LVEF, but they have pronounced concentric remodeling with impaired diastolic filling, in fact, a restrictive physiology where the LV ejection fraction is normal, but the flow, the pump function is reduced, similar to what we see in patients with heart failure and preserved LV systolic function. So this is another challenging group of patients because these patients, they are in low flow, so they may also have a low gradient despite a severe stenosis. And let me show you two representative cases here where actually you have on the right the classical low flow with the low EF, and on the left the paradoxical low flow. So obviously these two patients have markedly different LVEF, but they are both in low flow. The cause, the mechanism of the low flow is different in these two patients. Here, systolic dysfunction, here, more restrictive physiology. But the result is the same. What goes out from the ventricle is reduced. And so these two patients have a low gradient, not very impressive gradient, although I can tell you that both had a severe stenosis and got operated. So let's start with the classical low flow, the one that we know better, with the low EF, etc. So in these patients with low EF, low flow, small valve area, and low gradient, what we typically do is a dobutamine stress echo or CAT. It's a low dose. It's not the same protocol that we use for ischemic heart disease. We go up to 20 mic dosage. And if the patient, the ventricle respond to dobutamine, if there is any contractile reserve, which is now in the guidelines, they don't call it anymore contractile reserve, and I think it's good. It's more flow reserve because it is defined on the basis of a % increase in stroke volume equal or more than 20%. So if you have this criteria, you could say that you have flow reserve, and this is a good news for the patient because it's generally associated with better prognosis. So if there is flow reserve and the gradient increase markedly above 40, the valve area remains small, this is consistent with true severe stenosis and a good indication for valve replacement, surgical valve replacement or transcatheter valve replacement depending on the comorbidities. On the other hand, if the gradient remains below 40 and the valve area opens and becomes larger than 1 centimeter square, this is rather a pseudo-severe stenosis. So here there is no indication for valve replacement, but these patients are sick patients. They need aggressive heart failure therapy, as we'll see in a minute. And now you have about 1/3 of the patients who unfortunately have no response to dobutamine. So there is no flow reserve, no significant increase in flow. And the first challenge with this patient is that the stenosis severity often remains indeterminate with dobutamine because there was no change in flow, right? So what we can do in this patient is use other modality and multi-slice CT to assess the aortic valve calcium score, the aortic valve calcium load. And using these criteria, we can corroborate the presence of a true severe stenosis. The second challenge in these patients with no flow reserve is that they have very high operative risk with surgery, as I will show you. And so in these patients, TAVR, so transcatheter valve replacement, or a stage approach with balloon valvuloplasty first and then TAVR 6 months later if symptoms and LV function improve might be an alternative in this challenging patient. So this is what we do. So a low-dose dobutamine protocol up to 20 mic, and what we would like to see is this increase in the time velocity integral, so in the LVOT, so this increase in the stroke volume. So here we can say that there is clearly a flow reserve, and in parallel we see in these patients an increase in gradient that becomes higher than 40, so that would be a patient with flow reserve and true severe ES. So I'm going to show you a few cases to illustrate this concept. So we have here this first patient. You see that there is some response to dobutamine, the LV ejection fraction is improving, the stroke volume increases, so there is flow reserve. The valve area remains unchanged, around 0.75, so remains severe. And the gradient that was moderate at rest 29 is now up to 52. So here, this is a typical case of patients with flow reserve, true severe ES, a good candidate for surgical valve replacement, okay? Now, this other patient here also had some increase in stroke volume and LV ejection fraction, started from a very low LV ejection fraction. And here, so we have flow reserve in this patient as well. But as opposed to the previous case here, you see that the gradient increased very slightly, probably it's not significant. But the valve area that was severe at rest is now up to 1.2, so spectacular increase in valve area. So this is a typical case of patients with flow reserve, pseudo-severe ES. Here, the valve was not completely open at low flow, and now you increase the flow, and now it shows you the truth, right? So these patients, if you look in the literature and you look, the natural history of pseudo-severe ES, there is very little data. But there is this study from the French multi-center study of low flow, low gradient, where they defined pseudo-severe ES as a mean gradient remaining below 40 and a valve area equal or more than 1.2 during dobutamine. And they look at the outcome of these patients with pseudo-severe ES who were all treated medically, so no valve replacement. And you see that the outcome, the survival, is much better than patients with true severe ES or patients with no contractile reserve, no flow reserve, also treated medically. And in this study, they also matched these patients with pseudo-severe AS with a group of patients with heart failure, but no aortic stenosis, no valvular disease, and the outcome was similar. So the take-home message here is that pseudo-severe AS, as identified with Dobutamine stress echo, can be adequately, safely managed with aggressive heart failure therapy. They do not need surgery now. They need close follow-up because they may need surgery in the future if the stenosis progresses or if the heart failure therapy fails. So now we are getting into even a somewhat more complex case here. A woman with multiple risk factors, previous history of CABG, 1 year following CABG had a myocardial infarction. She's in congestive heart failure, has now an aortic stenosis plus some mild MR, many medications on board. And here, what we see with Dobutamine, some slight improvement in LVEF, but the stroke volume does not increase significantly. So probably the improvement in LVEF with not really significant increase in stroke volume was due to a worsening in MR with Dobutamine stress echo. And here we consider there is no significant flow reserve. And you look at the parameters of stenosis severity, the valve area and gradient, and there is no significant change, which was expected because the flow doesn't change in this patient. So here, what can we say? Well, we can say, well, there is no flow reserve, which we know is a marker for high operative risk and worse prognosis. But stenosis severity, I don't know. With Dobutamine, I don't know. And this is where we use more and more multi-slice CT, and we assess the calcium load, the calcium score, and to differentiate a pseudo-severe stenosis versus true severe stenosis. I showed you 2 examples. Pseudo-severe stenosis, if there is very little calcium on the valve, probably it is consistent with non-severe AS. If you have a heavily calcified valve like this is consistent with true severe AS. One thing, however, which is extremely important that we realized recently with a study that was a collaboration between Mayo, Quebec, and Bichat, where actually we found you need to use different cut point in men versus women. So in women, this is to identify hemodynamically severe stenosis, this is a calcium score higher than 1200 in women, versus 2,000 in men. So it's a big difference. And you see the case I showed you with no flow reserve. There is a calcium score of 2,000, which for women is clearly consistent with true severe stenosis. And we say, well, of course, women, they have smaller aortic annulus, so you need less calcium to get to severe stenosis. But we also index the calcium score for the size of the annulus, and still there was a difference, an important difference between men and women. And interestingly, the same cut point predicted very well, this is a more recent paper that we also published in JACC, predicted very well the mortality in the whole cohort as well as in patient treated medically. Again, calcium score higher than 1,200 in women and more than 2,000 in men. And even if you index for the cross-sectional area of the aorta, the cut point are 300 in women and 500 in men, so still an important difference. So why do we still have this difference between men and women, even when we index for aortic annulus size? We don't know. But as you know, it is very difficult to unveil the mystery of a woman's heart. So in this patient, we can say that the case number 3, well, there was no flow reserve. With calcium scoring and this 2,000 calcium score, we can say, well, there is true severe stenosis. On the other end, we know that the operative risk is very high with surgery, and this is what I will show you here. This is the French multicenter study here, where you see if you have flow reserve, what they call at the time contractile reserve, so this percent increase in stroke volume equal or more than 20%, and you undergo surgery, this is the group 1, the white curve, you have an excellent prognosis. If you're treated medically, very poor. Now, if you have no flow reserve, this is group 2, yellow, well, the main issue, as you see, is this drop in the curve. You have a very high operative mortality. In this initial series, the 30-day mortality with surgery was 30%, which was prohibitive. But still, it is interesting to see that despite this very high operative mortality, the outcome is still better with surgery than with medical therapy. And in a further study where there were more patients from the same group, but this was much later, and where they included only patients with flow reserve, you see that you have a better prognosis with surgery compared to medical management, although you have this high operative mortality, which was somewhat lower here, but still 22%. And after propensity score matched analysis, because of course we know that patients treated medically and surgically are not the same in terms of baseline risk profile. But if you adjust for these differences, still, surgery is associated with a much better prognosis. And also, if you look at the improvement in LV ejection fraction, interestingly, it is for the patients who survived operation. Of course, there is a survival bias here, but the patients who had no contractile reserve, the improvement in LVEF and in symptoms was as good as those with flow reserve. So the message here is that the absence of contractile flow reserve should not preclude the consideration for valve replacement. However, we know it's a marker for high operative risk, and it might be an argument for using transcatheter valve replacement. And in this regard, with my friend Stam and the team here, and Salim did a great paper that is in press. Stam should be published soon. Looking at the prognostic value of the contractile reserve, the flow reserve, in the following TAVR with the Emory experience. And well, again, we see some similar signals. So still, I mean, these patients, at least in the initial series, because this is the initial experience, they have worse prognosis. And of course, I think we need more data to see, well, is TAVR better than SAVR in this population? So we need some more data, some registry or randomized trial. So what do we have in the guidelines? Well, this is the 2014 ACC/HA guidelines. This entity, this classical low flow, low gradient with the low EF, was defined as a stage D2, which is, a progression stage of valvular disease. D2 is almost the maximum, Then after you have D3, but so it's a very advanced stage of the disease, as you may expect. And it is defined according to this criteria that I already mentioned. And there is a class 2A recommendation for valve replacement if the patient shows a mean gradient equal or more than 40 with a valve area equal or less than 1 at any dobutamine dose, okay? This is what you have in the guidelines. However, they do not mention the issue of flow reserve. What do we do if we have no flow reserve? So this is not directly addressed in the American guidelines, but in the European guidelines, they have a class 2A recommendation for valve replacement in this patient if they have evidence of flow reserve and a severe stenosis about defined with the same criteria, so the gradient higher than 40 with the valve area smaller than 1. But if there is no flow reserve, it's a 2B, so somewhat weaker recommendation because of the high operative risk, okay? And this is maybe the subset in patients where we think that TAVR or a stage approach with balloon valvuloplasty and TAVR might be useful. So what do we do in this case? Well, medical, we know I showed you the curve. This patient has no flow reserve, but there is clearly evidence of true severe AS. So with medical therapy, the prognosis will be terrible, right? But surgery, this is probably how you feel when you are the surgeon and you have to operate on this patient, a row score of 60%, no flow reserve, very high BNP, etc. So finally, there are, I think, two options that we consider, either the TAVR now or doing a stage approach. Our cardiologists decided to do a TAVR. The hemodynamic results initially were good. We brought down the gradient from 30 to 7. And more importantly, the evolution after, it was done transapically at the time. I should say that now we will probably have used another route. And the LV ejection fraction improved, BNP decreased, and more importantly, the 6-minute walk test improved. So it was a success in this patient. It's not always like that, but so another important thing, when we decide finally to operate on this patient, we need to avoid something that I was very interested, as Tam mentioned, which is avoid prosthesis-patient mismatch. Prosthesis-patient mismatch is when you have a prosthesis that is too small in terms of effective orifice area in relation to the patient body size and cardiac output requirements. And so it is, in other words, a residual aortic stenosis. And these patients, you want to have a completely free LV outflow tract, no residual gradient. Because if you change a low gradient of 25 by another low gradient of 18, you probably does not help much the patient, right? So, and this is what we showed, some time ago, where actually mismatch had a very important impact on operative mortality, particularly in the patient who had pre-existing dysfunction. And so severe mismatch was associated with very high risk, but even a moderate mismatch was not well tolerated in this patient, because it comes back to the concept that a moderate aortic stenosis or moderate mismatch may be well tolerated by a patient with a good ventricular function, but the same moderate stenosis may be poorly tolerated by a failing ventricle.
What are your definitions of moderate and severe?
Moderate and severe for mismatch. So, the classical definition that we use, moderate is when we use the indexed effective orifice area, and so this is between 0.85 and 0.65, and severe is below 0.65. Of course, and we could discuss that, but the issue is when you get with obese people, then you may, of course, overestimate the severity of mismatch, so you have to be careful. And so, well, there are different options that the surgeon can use to prevent mismatch, and this center is one of the major center and innovator in this field, but there are several neurogeneration of bioprosthesis you can use. There are some more invasive procedures that you can use. Root enlargement, but again, there is the risk-benefit ratio. And TAVR has recently become an interesting alternative, and we published recently on this topic. This is the initial study that we did with my friend Joseph Rodez-Cabal and my former PhD student, Marianne Clavel. This was a case match study, not randomized, but we matched according to annulus size, body surface area, etc., and found that the transcatheter valve was associated with much lower incidence of mismatch, especially severe mismatch, compared to the stented bioprosthetic valve, but also compared to the stentless. Here we use the Medtronic freestyle, but and this was particularly obvious in the patient with small annulus. So TAVR is really working very well in patients with small annulus, and we found the same thing in the post-hoc analysis that we just published in JACC of the PARTNER 1 trial, the PARTNER 1A. So you see in the randomized arm, SAVR versus TAVR, there was significantly less mismatch, severe mismatch in TAVR than with SAVR, and there is even less in the continued access registry, where probably the technique and the learning curve is even better. And where the difference was the most striking, again, is the patient with a small annulus. This is really where TAVR becomes really superior compared to SAVR. So this might be an option in this patient as well. On the other end, as you very well know, the Achilles heel of this procedure is that, yes, you have better airways, lower gradients, but you have more regurgitation and paravalvular regurgitation. This has been shown in multiple studies, including the PARTNER trial, and we know that there is a signal associated with that. Moderate, severe, and even mild paravalvular is associated with increased mortality, about twofold increase in mortality. So what will be, and this is the central illustration that we published with the PARTNER paper in JACC and mismatch, what would be the net benefit of avoiding mismatch and residual stenosis versus having the risk of paravalvular regurgitation in these patients with low flow, low gradient? We don't know yet, but we have some clues still, because there is this very interesting post-hoc analysis that we did with Owe Herman, again from the PARTNER trial. This was the whole PARTNER, so 1A and 1B. And this is the subset of patients with the low EF, low flow, low gradient, so the classical low flow. And you see that the medical therapy in green, that's first in the cohort B. So the cohort B, remember, is the patients who are not operable and randomized to TAVR versus medical therapy. And you see that TAVR in white was associated with marked reduction in mortality compared to conservative management. And this is the only randomized data that we have. And there is some limitation because it's a post-hoc analysis, but this is very spectacular. On the other end, if you look at cohort A, so that was the high-risk patients, so this is the SAVR versus TAVR here. There was no significant difference in mortality between SAVR and TAVR in these patients. There is, however, one thing I would like to bring to your attention. In this trial, there was a selection bias, because first, we excluded the patient who had very low LVEFs, like some patient I showed you, lower than 20% was not included. And also we excluded the difficult patients with no flow reserve, because to get into the trial to qualify, you needed to reach a mean gradient of 40. And if you have no flow reserve, it's difficult to achieve this 40. So you remove an important high-risk subset of patients. So we need more data to know what's going to be the answer. We have this study that we did with our friends in Vancouver, with John Webb, etc. And here we found that in patients with classical low flow, low gradient, and here there was no exclusion criteria with regard to LVEF or with regard to flow reserve, and we found that TAVR was associated with better and faster recovery of LVEF compared to surgery. But this was not randomized, so this should be interpreted with caution. So let's shift gear now and talk about this other entity, which is even more intriguing, the paradoxical low flow, low gradient with preserved EF. So here I show you another case. So this is a 70-year-old woman. She is symptomatic. She has some mild hypertension, but well controlled medication. No evidence of CAD, but she never had a coronary angio. She has a preserved LVEF, as we'll show you. And, on echo, I have a valve area of 0.7, index 0.4. So if you stop here, I say, well, what's the point? You have severe stenosis, you have symptoms. This is a class 1 indication. But the problem is that the gradient, the mean gradient, is only 29. And of course, one could say, well, this is not compatible with the severe stenosis, especially in patients with preserved EF. So I show you here the video clips are not playing well, but what you can see clearly, you have a pronounced concentric remodeling here with a very small cavity. The LV and diastolic volume is estimated at 79 ml. The LV ejection fraction is clearly normal, although it might be difficult to appreciate, but I can tell you that both by Simpson visual was around 60%. The valve, if you can see, it does not look bad. It does not look good. I mean, it is calcified. You see some restricted opening, so it's not a normal valve. And this is an important criteria. We need to look at the valve. And as I said, by continuity equation, I got a 0.7 centimeter square valve area, and the gradient is much lower than I would expect for such a small valve area, especially with a patient with preserved EF. And well, the reason for this disconnection, this discordance, might be the presence of low flow, because if I look at the stroke volume measured in the LVOT, it is pretty small. 46 ml is what we see in patients with low EF. And when you index, you see the stroke volume index is 27 ml per meter square. The cut point to define low flow that we propose and is now in the guidelines is less than 35 ml per meter square. Again, there's some issues in obese people because you may kind of overestimate this issue, but obviously we have a low flow here. But the first thing that comes in mind when I have this situation is measurement error, because I may have underestimated the LVOT diameter. I mean, it's difficult measurement, especially in patients with calcific ES. I may have underestimated the LVOT velocity. So that's why it's very important to corroborate this measurement by other methods. What we do, you could use a 2D volumetric method, or even a good Tychols with the LV and diastolic volume estimated by Tychols, and then you multiply by LV ejection fraction, gives you, another measure of the stroke volume. And if the numbers fits like here, well, you're reassured. In this patient with this small ventricle and this LV ejection fraction cannot eject a normal stroke volume. This is impossible, So this is reassuring. This is certainly not enough to refer the patient to surgery, because you have not confirmed that the stenosis is severe. You can say, well, I think what I'm measuring here is real, but I need more. What we did in this patient is a low-dose Dobutamine stress echo, and well, there was here a marked increase in gradient with no change in valve area, similar to what we see in patients with the low EF, okay? If you don't believe in Dobutamine stress echo in this patient, well, use calcium scoring. That's another option that we use more and more in this patient, because these patients with preserved EF, especially when they have concentric remodeling, impaired feeling, they do not necessarily respond well to Dobutamine. So we use more and more calcium scoring. And in this lady, we had a high calcium score, both in absolute term and index for the cross-sectional area of the annulus. The cut point are 1200 and 300. So obviously, this is consistent with severe. So, and this is important to do this exercise, because according to this study that we did with some other centers, about 1/3 of the patients have pseudo-severe ES among these patients with paradoxical low flow, low gradient ES. So this is about the same proportion as the patient with low EF. So remember, in patients with low flow, low gradient, whatever the LVEF is normal or reduced, you have about 1/3 of these patients who do not have a severe ES. And you need to rule out this situation because you don't want to send this patient to surgery. So this is actually this. So this lady had a what we described in 2007, a paradoxical low flow, low gradient severe ES, and this entity, is, as you know, more frequently seen in elderly people. I'm sure in your practice you see that more in elderly women with often concomitant hypertension, with often insulin resistance, and this predisposed to this pronounced concentric remodeling with a shrinking of the cavity. Where, for example, here, this patient had normal LVEF, but the gradient is only 30 measured by CAT, although she had a severe stenosis, because the stroke volume is reduced. So this is a summary of the features, of the Doppler echo features that you can identify to well identify this patient with paradoxical low flow. You expect to see a small valve area, and it is important to index for body size. And one thing that we use a lot also in this patient is the Doppler velocity index. So it's the ratio of V1, V in the LVOTs, to the velocity of the trans-aortic flow. This is in fact the aortic valve area minus the LVOT cross-sectional area. And you expect to see a small DVI, Doppler velocity index. If not, you should suspect a measurement error in the alveolar diameter. And well, of course, you expect to see a bad-looking valve. The mean gradient will be lower than 40 as you know, per definition, and this is what creates a problem because you have the discordance with the valve area. The valvular arterial impedance, which is, I won't spend too much time, but is typically high. You expect to see a small ventricle with pronounced concentric remodeling. What we call the relative wall thickness ratio is generally higher than 50, so this type of ventricle. If you have a normal-sized ventricle with a normal LVEF, and you measure a low stroke volume, there is maybe something wrong, you know. So, I mean, you need to find the explanation for the low flow. These patients have more myocardial fibrosis, as shown by MRI. Impaired feeding, what you typically see, you have increased E over E prime. And LV ejection fraction is truly normal. But if you look at parameters that are more sensitive to the systolic function, and we use more and more these parameters, and we should use more and more, the global longitudinal strain that we can now easily measure by spectral tracking, and I know that Stam is doing this routinely in the core lab. You see clearly, although the LV ejection fraction is normal, the longitudinal function is impaired. Typically, all the studies have shown that in this patient, global longitudinal strain is reduced. So because of this particular geometry, because of the impaired feeding, because of the impaired longitudinal shortening, the pump function is reduced, and so you're going to have this stroke volume index lower than 35. You are in low flow, and then the assessment of stenosis severity becomes more difficult. So this is all the mechanisms that contribute to reduce the forward flow in these patients with aortic stenosis who often have concomitant hypertension. But you have other things that we often see in the elderly population with calcific AS, especially in the TAVR population. These patients often have atrial fibrillation. It's very frequent in this population. They often have mitral regurgitation. How many TAVR patients have concomitant MR? TR, we see a lot of TR and very significant TR. Mitral stenosis, we see a lot of calcification of the mitral annulus in this elderly population. And all these factors will contribute to reduce the stroke volume, although the LV ejection fraction is normal. And that's why we have in the partner trial, 45% of the patients were in low flow. So it's a very large number, but it corresponds to the reality. These patients have low flow. And if there is low flow, there are some less frequent factors. Well, if you have low flow, you may have a pseudo-normalization of the gradient, and then it creates a more difficult entity. So people often ask me where this 35 ml per meter square come from, you know, to define low flow. Well, this was in our original study in 2007. We did a sensitivity specificity analysis with regard to outcome. But there's been a study published, and then after, all the studies came out with about the same cut point, same in the partner trial, was pretty close to 35. And in this study was published 2 weeks ago, I think, in Heart. And actually, this is from the Mayo. And you see that there is a progressive increase in the risk of mortality when the stroke volume is decreasing. And you start to see some impact when the stroke volume index becomes lower than 43, which is not very low. But clearly, if you look at the curve where really the risk is getting much higher is when you have a stroke volume index lower than 35. So it somewhat validates, again, this cut point that is now in the guidelines. With the caveat, of course, that as anything that is indexed for body surface area, you should be careful in overweight and obese people. So one of the important things now is, do these patients with paradoxical low flow have worse outcomes? Because if they have the same outcomes as others, you know, well, it's interesting, but not that much. So this is the initial study that we did. And in this study, we separated normal flow versus paradoxical low flow. But at that time, we did not separate low gradient versus high gradient. That was a mistake, but you know. So then subsequently, with this paper with my colleague and friend Jean Duminil, we recommended to separate the patient with preserved EF according to flow and gradient in order to better, you know, re-stratify and guide the therapeutic management. So you have the normal flow high gradient, normal flow low gradient, and then you have low flow high gradient and low flow low gradient. And as you see from this study from Belgium, this helps to stratify the risk of cardiac events. The patients with the paradoxical low flow low gradient clearly had the higher rate of events, whereas those with normal flow and low gradient have the best outcomes. And you may say, well, if you have a normal flow and a low gradient, you probably do not have a very severe stenosis, right? And the other groups were intermediate. Same results in this study from the Mayo. This was a pretty large study from about 1,700 patients. And you see again, the worst group is the paradoxical low flow low gradient, followed by the low flow, low gradient, and the two group with normal flow had the one in dot curves were had good outcome. Now, there are, however, some data in the literature that do not go in this direction. This is a sub-study from the SIS trial. So you remember the SIS trial is this randomized trial, placebo versus statin, to see if it would, statin would have an effect on aortic stenosis progression. Unfortunately, this trial was negative. But they compared the outcome of patients with small valve area and low gradient. They didn't take into account flow in this first classification. So it's a more discordant grading, you know. And they compared with patients with moderate AS, so valve area between 1 and 1.5 and low gradient. They also had a patient with severe AS, but very, actually it is not shown here, very few patients because by study design, these patients were excluded. And you see that the outcome was similar, which was somewhat surprising, but you know, and when they separate low flow versus normal flow, you know, same thing. However, I should mention that in this study, 70% of the patients were low flow, although this is a population with asymptomatic moderate AS, which probably, and the authors acknowledge this, probably emphasize that probably a large number of patients had measurement error, because 70% of low flow in an asymptomatic population with moderate AS does not make sense, whereas all other studies reported less than 40, 50%. So, so this, I think, emphasized that when you have this discordance between valve area and gradient, so the small valve area, let's say the 0.8 with a mean gradient of 30, the first thing and the first cause, most frequent, is measurement error, okay? So that should be ruled out. Small body size, because if you have a small valve area in a small patient, this may correspond to moderate AS. So it is also important, and some studies did not take into account this factor. It is important also to take into account the index valve area, because if you index and you have a index valve area of 0.7, okay, you got your answer, you know, it's small body size. This one is more difficult. There is inconsistency in the guideline criteria, unfortunately, because from a fluid mechanics standpoint, you know, the cut point value of valve area of 1 centimeter square that we have everywhere to define severe stenosis does not correspond to the cut point value of the mean gradient of 40. The intersection, if you just do a calculation with the Gaulian formula, you put a normal flow rate, you put a valve area of 1, you won't get a mean gradient of 40. You would get a gradient more than 30. So some patients are misclassified because just of these inherent discrepancies. And these are most often the patients with the normal flow low gradient I was talking about. They generally have better prognosis. And then it could be a true paradoxical low flow low gradient CVS. And this is the only situation where you may eventually need valve replacement. So, and I think I won't spend too much time because, I mean, you're expert in the field, but measurement error are very important to rule out because we know that we may do some measurement error in the LVOT diameter. I can tell you that we prefer the green measurement at the base of the cusp, although the AAC guidelines recommend a measurement lower in the LVOT, but lower in the LVOT, we realize that we often underestimate. Also, we have to be careful with the velocity in the LVOT. And the velocity also, by continuous wave Doppler, the transaortic velocity, we need to really do a multi-window interrogation, and in 30% of the case, you're gonna get the maximum velocity on the right parasternal, not the apical view. So we did this study, and it was a bit in response to the SIS trial, where we actually really have been very careful in characterizing the paradoxical low flow low gradient, confirming the measurements of stroke volume and the valve area by several methods, and we compared the outcome with the moderate AS and with the patients with normal flow and high gradient. And there was a big difference in outcomes. You know, I think when it's true paradoxical low flow low gradient, you know, all the factors that contribute to low flow, none of them will improve survival, right? All the factors I showed you, so it does not make sense that patients with low flow have same outcome or better outcomes, you know, except if it's measurement error. So same from this is from the Mass General. They obtain the same results. Low flow, low gradient have worse outcome. And here they have the moderate. And they also have, you know, this group with normal flow, low gradient, probably those who are misclassified because of the misalignment of the guideline criteria. So same results from different institutions. Now the very and last important thing in the last 5 minutes is, does AVR improve outcome in this patient? Because maybe they are too advanced stage of the disease, it's too late, you know, we cannot help them. And this is, again, a study from our center. Of course, not surprisingly, in the patients, the normal flow, high gradient severe AS, valve replacement is associated with huge benefit compared to medical therapy. No surprise. But even in a paradoxical low flow, low gradient, you have a spectacular improvement, even if you adjust for propensity score and baseline characteristic. There is, however, a price to pay that you see at the beginning of the curve. You see this patient have somewhat higher mortality, operative mortality compared to the normal flow high gradient, because they are at more advanced stage of the ventricular disease. They are somewhat higher risk patients. And same results from the Mayo here, showing a huge benefit of valve replacement on multivariable analysis in these patients with the low flow, low gradient. So clearly it improves therapy. But maybe the study that I think is the most important, because all the studies I showed you so far are non-randomized, is again this post-hoc analysis of the partner trial. This is maybe one of the only opportunity that we're going to have randomized data between medical and valve replacement, right? So here, this is the subset of patients with normal EF, low flow, low gradient, so the paradoxical low flow. And first in the cohort B, you see that TAVR in green was associated with marked reduction in mortality compared to the conservative management. So I think it's a proof that this TAVR or aortic valve replacement in general helps this patient. The other interesting thing in this analysis was that in the cohort A, so the high risk, well, TAVR in blue was associated with significantly better survival, so reduction in mortality, compared to SAVR in yellow. And this was significant for the first year and a half, and then after the curves merge, because this patient have many comorbidities. But this maybe indicates that TAVR may offer some advantages in this patient, because these are patients with small thick ventricles, small calcified aortic root, and they are challenging patients for the cardiac surgeon and for the anesthetist. Plus often that these patients often leave the OR with a prosthesis-patient mismatch. So there might be some advantage, although of course we need more data. These are very recent data that we have not published yet. I would like to share with you, showing how the flow is changing with intervention. Interestingly, both in the classical and paradoxical low flow, we have an increase in flow, significant increase. The increase in flow, this is all following TAVR, okay? And the flow increased faster and somewhat better with the transfemoral approach compared to the transapical. And I think this is consistent with many studies showing that the transapical is associated with somewhat more myocardial injury. So in these patients who are highly vulnerable, if we can avoid the transapical, and go transfemoral, or if not available, transaortic is probably better. So, and the other thing, if the patient does not improve the stroke volume, does not normalize the stroke volume index immediately after TAVR, this was associated with higher mortality. So what do we have in the guidelines? This is new in the guidelines, because before this was not existing, because the entity has been described in 2007. So both in the European and American guidelines, there has been a new Class 2A recommendation for this patient. First, well, this stage is considered a D3, which is the maximum in terms of progression. It is defined as a small valve area, and you see they also added index valve area. You have a mean gradient lower than 40, you have the preserved EF, and you have the stroke volume index lower than 35. And there is a Class 2A recommendation for valve replacement, but there are some very important things that are emphasized. The patient needs to be symptomatic. You need to have a confirmation of the severity of the stenosis. And also, in the ACC guidelines, they mention that the patient needs to be normotensive, because hypertension may be a confounder here, and these patients often have concomitant hypertension. So to finish, I would like to show you the algorithm that we use in these patients, because they are a difficult group of patients. I think the first step, when you have this combo of small valve area, low gradient in patient with preserved EF, and apparently low flow, try to rule out measurement error. This is very important. And also, you have low flow, but you need to identify the cause of the low flow. Again, if you have a normal ventricle, you have no MR, patient is not in AFib, patient has preserved EF, does not make sense that we have a low flow, right? If you can identify the cause of low flow, then you can say, well, okay, I'm probably good. The second step, then, symptoms. Because if the patient is asymptomatic, eventually confirmed by exercise testing, I think stop here. Close follow-up is okay. There is no, even if you don't know exactly if the stenosis is severe or not, it's not a big deal. If the patient is symptomatic, then definitely the next step, as emphasized in the American guidelines, check for hypertension. And if there is hypertension, we need to initiate or optimize the antihypertensive therapy and reassess. Because hypertension may contribute to the low flow, so the discordance between valve area and gradient, and the symptoms and worse outcome. We had some patients who had some kind of uncontrolled hypertension. We treat them with hypertension, the flow increased, the symptoms regressed, and actually the discordance between valve area and gradient also disappeared, because the valve area increased. So, and if despite optimization of antihypertensive therapy, you still have symptoms, you still have this entity, of course, the last but not the least step is to confirm stenosis severity, because again, about 1/3 of these patients have non-severe AS. I should say that our preference now, that our first, although we published with low dose Dobutamine stress echo, it is often not applicable in this type of patients. So we tend to prefer now aortic valve calcium by scoring by CT. It's not a panacea, it's not perfect. And we can discuss, there are some false negative and some, but this is what we use. And if you have evidence of non-severe AS, well, close follow-up. If evidence of true severe AS, yes, of course, we need to consider surgical or transcatheter valve replacement. So the key message, I think, in these patients, we need to rule out measurement error, small body size, the normal flow low gradient, which is more inconsistency in the guideline criteria. If you have a normal flow, this is somewhat reassuring. These patients have better outcomes. They probably not have very severe stenosis. And rule out pseudo-severe AS, I would just mention. AVR improves outcome in these patients with low flow low gradient. Severe AS, of course, you need to confirm the severity, regardless of the LV ejection fraction. And TAVR, I think this is really a subset of patients where it may have an important role, both in the classical and paradoxical. But we need more data, and this is why we have this multi-center study, the TOPAZ TAVI registry. I mean, the TOPAZ study is a prospective study of low flow, low gradient, and I'm very proud to show this slide because Emory, by far, is the best recruiting center. So thank you so much. And continue the good work. I mean, that's going to be, we plan to do a first paper once we're going to reach the 150 patients, and we're aiming to have 300. And this is classical low flow, but the next step would be paradoxical low flow. So thank you so much. And I just finished with this image, which is not Photoshop. This is a real photo. But this is just to emphasize that when you have this discordance between valve area and gradient, when you think you have a low flow, low gradient, it is important to make the differential diagnosis. Because here you see this shock, which is potentially very dangerous for the surfer, is not a shock. You need to carefully examine the back tail, which is in fact horizontal and not vertical. So this is a dolphin. And I thank you very much for your attention.
Thank you, Philippe, for this superb presentation. And we're looking for any questions.
So Philippe, thank you for coming. We've really enjoyed having our Canadian colleagues come, just said before, and just an immense contribution to the literature with all the low flow gradient you've been doing over the years. So first of all, congratulations. I have a comment and a question. So one comment is, in our algorithm, which we do things very similar. We have not been doing the cardiac CT for calcium because we do have some patients that don't have a lot of calcium, still have aortic stenosis. But one thing that we found that has been helpful is to do a trial of balloon aortic valvuloplasty on some of these patients that I know I saw it there in your list, and maybe you didn't get to it, but just to make a comment that we do use this, and if people have not just one-day relief, but sustained improvements. You see them back in the office 1 month later, and they say, I feel a lot better, quality of life's improvement. We will go after the valve, usually with TAVR, because a lot of these patients tend to be high risk. So that's something we've put in our algorithm. Other things that we've looked at with STAM is also to do MRI to try and understand how much scar is in the myocardium, some of these patients with no contractile reserve. The more, obviously, more scar you have, either whether it's mid-wall or transmural, if they're ischemic, et cetera, less likely that they're going to have recovery of ejection fraction. But if, in fact, you see no scar, and there's no other reason other than aortic stenosis, even without contractile reserve, we'll implant these patients, and they do very well. So that was just a few extra things to add to your list, but they're just phenomenal how you guys have worked that out. So here is my question now. How, because we have our own mechanisms over here, but you have emphasized very carefully that making errors in measurement can throw you completely off, right? You can have a low flow, you might have a normal flow, but it was, and so forth. What have you done in your imaging lab to standardize this? Have you sort of concentrated this in a few people? Is there only one or two attendings that look over all of these type of studies? Do you have specialists in areas? Do you have a certain, 3 or 4 sonographers you picked out? How do you standardize the quality so that every single time you're looking at the results of your study and you feel very confident?
Yeah, that's a very good point. I will first answer the question and then come back to your comments that are very important. Well, sorry for that. Given, I mean, we have a very large volume echo core lab, so echo lab, an echo core lab as well. But it's very difficult to restrict, the patient with aortic stenosis with many, per day, as you know. So everybody is doing the measurement. However, we have specific sessions, where we really train the people on how to measure, and we put lots of emphasis on this measurement. And the good thing, because of the influence of Jean Duménil a long time ago, the stroke volume has been measured in the echo lab in every patient, not only the patient with aortic. This has been for a long time. So I think the techs and the cardiologists are really drilled on how to do that. And the good thing now with the echo core lab, many of the tech working in the clinical lab also work in the core lab. And so we have training session, and we show difficult cases when you have calcification and things like that. And as I said, it's really how you get the image is very important first, because it's not only the measurement. You really need to open, the LVOT and really get the image providing the maximum diameter. The other thing, we measure at the base of the cusp, not in the, because the further you go down in the LVOT, the less circular it is, and then you have the septal bulge often in these patients. So where do you put your cursor, Whereas at the base of the cusp, you have some anatomical landmark. You're more at the annulus, not exactly, but more. At this level, it is more circular, so you have less error with regard to ovality. And also, when you're going to do the measurements one year later, you have the same anatomical landmark. Whereas if you say, the guidelines say 5 to 10 millimeter below the annulus, but from one echo to the other, it's going to be 5, another one is going to be 7, the other one would be 10, So whereas if it's the base of the cusp, you got more reliable. So that's one thing, And I know that you will see some publications saying, well, we should do hybrid measurements, where you're going to measure the size of the cross-sectional of the LVOT by CT and get the velocity by Doppler. First, it's a bit more complicated, because if for any patient going for an assessment of AS, you need to have the CT and plus the radiation, etc. Might not be the approach, but okay. Let's imagine that we do that. First, you have to consider that the CT is somewhat overestimating a bit the size of the LVOT. Interestingly, if you take echo, CT, MRI is in between. So you have MRI, echo is indeed a bit lower, but CT is a bit larger. And what we have a study currently showing that yes, indeed, echo somewhat systematically underestimates CT if you take the valve area calculated with the LVOT measured by CT. But now if you predict prognosis, because that's the point, you need to validate with outcome, then it's not the same cut point that we should use. It's still 1 centimeter square with echo, but then it's 1.2 with CT. So that's the point. Okay, yeah, it's measuring something different, but we may also have to use a different cut point. That's, it's not that simple to say, well, we're going to measure by CT and then no, because you also need to adjust your cut point. And that's what we've done with, again, that's the same collaboration with Mayo and Bisha, validating with 1,000 patients with outcome, and it's not the same cut point. And I think regarding your comments, MRI, I think there is an important future, and we are investigating this in the context of the TOPAZ study, the potential of measuring myocardial fibrosis, focal and diffuse. I think may help for risk stratification. I'm not sure if we're going to decide, except if it's very, extensive, and say, well, this is probably a cohort C patient, and we should, maybe it's a heart transplant if eligible, but it's not a valve replacement. But otherwise, you're going to see some scar. I think it's going to help to say, well, this patient's not much scar, let's go for a SAVR or TAVR now. Whereas this patient, there's more fibrosis, maybe try what we mentioned, stage approach, because maybe this patient, we're going to do the valve replacement and we're going to not improve the symptoms. So let's do a balloon valvuloplasty first and then see what happens. I strongly believe that the balloon valvuloplasty has a challenging test, and eventually a step for TAVR or SAVR could be very interesting, as long as it is efficient. Because the problem is that in the partner trial, most of the balloon valvuloplasty were associated with 5 millimeters mercury reduction. So of course, if you have a balloon valvuloplasty that does not reduce the gradient, you will have no improvement that you cannot conclude. Or if the balloon valvuloplasty creates an AR. So, but if you have an efficient balloon valvuloplasty and you see some immediate improvement in the flow and then improvement in symptoms and nerve function, then go for it. If not, well,
together.
So it's Robert Guyton. I really enjoyed your presentation. In the concerns that you expressed about the calculated valve area were prominent as the guidelines were being developed, and there were many people on the committee who felt that we should be almost abandoning the calculated valve area altogether, looking at velocities, looking at gradients, and looking at volumes and stroke volume, ejection fraction, and LV volumes, and simply saying there are too many errors in the calculation of the valve area, and it leads to errors, particularly when the echo labs are not at the same standards of the core centers. What are your thoughts about essentially moving away from the calculated valve areas?
As you may expect, I'm opposed to that. But
that's what I thought.
but I think it's really if you have a high gradient, high velocity, I agree that we don't need to look at the valve area. I mean, you know that the stenosis is severe, you know. But on the other end, where I'm more concerned, if you have a gradient that is not severe, you know, and the patient is symptomatic, you know, the gradient that is between 20 and 40, and the valve area is small, then this should raise a red flag. And then we should do more. Probably maybe the valve area is not right, and that's the gradient was right, but you need to do more. And I think it's more. And what I said to the people now is, because there was also some discussion in the guideline as well to reduce the cut point, to lower the cut point from 1 to 0.8. And again, you know, we did a study with 2,000 patients, and we look at what predict the outcome. For valve area, 1.01 in the ROC curve analysis. For indexed AOA points, very close to 0.6. For the gradient, it was more 30. So then, actually, the outcome data tells us, well, no, they should not lower the cut point for valve area. Maybe we should lower the cut point for gradient. I'm not in favor of that as well. I think we have two parameters. One is highly specific, you know, the gradient, and the other one is highly sensitive. When the two fits together, you know, I think if you have a high gradient, it's okay. Don't look at valve area. If you have a low gradient with large valve area, you're done. You know, it's consistent. Where you have a discordance between the two, given that one which is highly specific and the other one that is highly sensitive, you need to do a tiebreaker. You know, and probably this is where you need to dig a little bit more. Try to see if it was not a measurement error. But I won't be comfortable, because then we're gonna have a substantial number, and there is more and more data showing that you have a substantial proportion of patients who do not reach the 40 millimeters of mercury of gradient and still have a severe stenosis and still benefit from valve replacement. Especially, you know, in the population that we have nowadays, you know, the elderly population with one over two have a reduced flow, and you know, this is fluid mechanics. You know, when I work with biomedical engineers, I say, well, gradient is rubbish, because it's highly flow dependent. Why do you work with that? Why do you want only, you should work with vena contracta. Yeah, but because in vitro, the biomedical engineer, they can use PIV laser, and they measure the vena contracta very accurately. But in terms of fluid, of physiology, the effective orifice area is the best parameter. The problem is that it is difficult to measure. But so I think we have to consider everything. And the Doppler velocity index as well. You know, it's another interesting tool. There will be some publications showing that it helps in this patient. Because, you know, if you have a small valve area, but a normal Doppler velocity index, maybe there is something wrong. So I think we have, the beauty of echo is that we can measure many parameters of the same phenomenon. So we should use all the parameters. Where I think we're going to be wrong in when we rely only on one parameter. That's my position.
Getting along with that measurement error, you know, which I think is a big issue, like in practice, is, do you feel there are parameters that we can use in the guidelines? It specifically kind of indicates, along with that maximum velocity, that like if it's less than 3, you shouldn't even consider that this would be a severe aortic stenosis. It wasn't really brought up in the talk today, but that's kind of how the guidelines have. And I guess the second part of that question is, the data before this phenotype you described in 2007, a lot of the studies, I would assume, when I remember looking at this, would probably include patients with the remodeling patterns that you described, yet the max velocity was still pretty much the main predictor of outcomes. So do you think that this population was maybe underrepresented in previous studies, and that's why we need to look more into the valve area and this paradoxical?
Yeah, I think, in most of the studies that were done originally, if you think about Catherine Otto, in 1997, and the studies and Raphael Rosenek, this was really patients with pure, I should say, aortic stenosis and not many comorbidities, and they were enrolled in prospective studies. But nowadays, this does not necessarily reflect the population that we have. Again, I think we have many patients who have, they are often elderly patients, they often have concomitant hypertension, coronary artery disease, so many reasons for not having a normal flow. I think that the original studies included a much higher proportion of patients with normal flow. They were asymptomatic at baseline. So generally, if you have a low flow, you're often not asymptomatic. You often have symptoms, because, and I think it makes a lot of sense to look at the flow. This is something that we have measured forever in the cath lab and the echo lab to calculate the valve area and the cardiac output, but we never look at it in terms of restratification. And when you come to think of it, the heart is a pump. It makes a lot of sense to look at what goes out from this pump, in terms of marker of performance. And I think, again, if you look at the guidelines, they don't say that valve area is not important. They say, well, if you have high gradient, high velocity, it's maybe not worthwhile spending much time calculating all the fancy other parameters. It's more when you have, and it's clearly indicated in the guidelines, when you have a low velocity or, gradient that is lower than 40, this is where you need to look at the stroke volume and valve area. And if they are small, then you need to corroborate the stenosis severity, look for hypertension and other things, which I think makes sense. I think the velocity and gradients are very important, and they have the advantage of being very reproducible. But remember, they are highly flow dependent. So when you have a condition where it's associated with the reduction of flow, they may be pseudo-normalized. Is there any cut point where we could say it's not probably not severe? I think when you have a mean gradient lower than 20, probably, because there is some point where you would need to have a very, very, very low flow to get a gradient of, let's say, 15 and still have a severe stenosis. So probably, and if you look in the literature, a mean gradient lower than 20 is generally associated with poor outcomes following SAVR or TAVR. Same in why? I think it's a composite marker of probably worse LV function and maybe more severe low flow, but this is also probably a marker of maybe less severe stenosis and potentially less advantage with surgery. So to me, I think the sweet spot is between 20 and 40, probably below 40, below 20, maybe it could be severe, I don't know. But even if it's severe, probably I know also that these patients that generally not do well with surgery, and maybe that's a case where you could try a balloon valvuloplasty to see if really is this 20 millimeters of mercury gradient really the actor of the problem and the symptoms, or simply a marker of other things. If with balloon valvuloplasty, nothing changes, and that's something that is very timely, because there is now a trial that is currently designed where they're going to address patients with moderate AS and would still have heart failure symptoms. So the patients with a mean gradient between 20 and 40 have heart failure symptoms, and they're going to try to do randomized conservative heart failure management versus TAVR. Because again, it comes back with what I said. Moderate AS in patients with a failing ventricle and heart failure patient may be equivalent to severe hemodynamic burden. So maybe by reducing this moderate AS, you're going to help a patient. But that's provocative.
Thank you. Thank you very much. Thank you.
The preceding program is copyrighted by Emory University.